So yeah, hello everyone. Welcome to the latest of our VetCT 12-minute take-home webinars, and it's great to see you. Just to inform you, if you don't already know, we've recently launched our new app and teleconsulting service. We'd love you all to give it a try. Through the app, vets get instant access to our great team of specialists who offer support and advice on tricky cases. You've got flexible options of how to communicate with the team through instant callback, text chat. You can book an appointment at a time that suits you or ask for a written report. And very excited because today we've launched a new easy way to interact, like having a specialist on speed dial. You can simply give us a call through the app, which helps you to learn actively while you're on cases. And if you're in the UK, this also gives you the added benefit of accruing CPD points while you're learning on the job. To try it, please download the app from the App Store or Google Play, and the QR code on your screen will take you directly to the app where you can register. And it's beneficial for both employed and locum vets alike. And if you want to know more, please do go to the website, or you can contact us, sales@vet-ct.com for more information. So on to today's 12-minute webinar. As a reminder, the session itself is being recorded and there'll be an opportunity to ask questions at the end. So just add them to the Q&A box and Lisa will go through those at the end. So let me introduce you now to our fantastic ECC team. So they're on hand 24/7 to answer all your questions and queries via the VetCT app. So we've got Mara, Chris, Melissa and Rebecca, and of course Lisa Smart, who is joining us today from Perth with today's session on the essential tests for abdominal fluid analysis. Over to you, Lisa.
Thanks so much for the introduction, Liz. I'm hoping that everyone can hear me okay. Liz, thumbs down if it's not coming through very well. Great. So today I'm going to be giving the 12-minute take home on the essential tests for abdominal fluid analysis. Next slide, please. I'm going to have to ask to change the slides, I'm afraid. Maybe I can do a little hand wave when we're going to change the slides. That might help the transition a bit more. I had some laptop issues this morning, I'm afraid. So what we're going to cover today is just really briefly talking about being able to identify and sample abdominal fluid, and then choosing the appropriate point of care tests that most of you should have access to in your practice, and then interpreting that result and prioritizing the interventions. And really prioritizing intervention for abdominal fluid, often it's the question of, do I need to go to surgery right now or do I not? So that's the most common question that we're answering when we are seeing these sick patients with free abdominal fluid. So in terms of identifying and sampling abdominal fluid, I'm sure that many of you are familiar with how to go about this. If you could just advance the slide, there should be some images on this, Liz. There we go. So point of care ultrasound is really your best bet for identifying the free abdominal fluid and for sampling it as well. Most people probably these days have ultrasound in their practice and are probably pretty skilled at finding free fluid and being able to sample it. So I'm not going to dwell too much on the technique of how to find free fluid, but there are resources out there on the AFAST technique. If you don't have ultrasound, then you may have to appreciate decreased serosal detail and abdominal radiographs, not as ideal, or maybe you might appreciate a distended abdomen and an obvious fluid wave. There has to be a lot of fluid for there to be a fluid wave. So they're only obvious in the more extreme cases. There are also techniques described for doing a blind abdominocentesis without ultrasound, focusing your needle around the area of the umbilicus. Next slide, please. So these really are the essential tests that you need to perform when you've sampled free fluid. First of all, if you see free fluid, get it. If you can get it, it's a really important diagnostic step for that patient. So if you see it, definitely get it. If the dog's overtly bleeding, maybe think about coagulopathy before sticking it with a sharp object. But most of the time, it's going to be a safe procedure to perform. So the 7 things that we tend to think about in bold, we've got appearance, packed cell volume, total protein, and cytology. So really basic stuff. You should do that on any fluid that you get from the abdomen. The 5th, 6th, and 7th are really tests that are driven by the first 4 tests and your index of clinical suspicion for which path you're heading down. So you won't necessarily do the 5th, the 6th, and the 7th test on every fluid. Next slide, please. So first of all, for fluid appearance, you're probably all familiar with this, but it can be quite informative. So it might look like blood. And sometimes we're fooled by that. It looks like blood, but the PCV is actually quite low. So when you first get that sample, don't think, oh, this is a hemoabdomen. It could be that there's only a very small PCV actually in that sample. Straw coloured is a typical appearance of a transudate or a modified transudate. And if it's bright yellow, then you might be suspicious of bile peritonitis. Sometimes we see brown fluid if it's a really yucky septic peritonitis that has quite a thick exudate in there. And also recognizing whether it's turbid versus clear is important. If there's lots of cells in there, it's more likely to be turbid as well as protein. Next slide, please. So packed cell volume, always important to perform on the fluid. With hemorrhage, the PCV is usually higher than the blood. As the animal goes into shock, fluid tends to go from the interstitium into the vascular space. So the PCV will progressively drop, even if it's marginally. So the abdomen's usually higher. If the PCV is lower than the blood, then it's usually just blood contaminated. So I've put some examples there of where you might have blood contaminated samples, such as a ruptured bladder, which might have some blood in it. Peritonitis often has a little bit of blood in it, just from oozing from the peritoneal surfaces. And perhaps you hit a blood vessel when you were doing the abdominocentesis and have contaminated the sample in that way. So if the PCV is lower than the blood, it's much less likely or unlikely to be a heme abdomen. Next slide, please. Total protein. So some people might call this total solids because it's on a refractometer and it's only an estimation of protein. You'll find some tables in various textbooks. So textbooks like Edinger or Silverstein and Hopper tend to have these tables of how to categorize effusions. And the cutoff ranges here do vary a little bit from textbook to textbook, but this is kind of how we classify, or roughly how we classify, the fluids. So if it's a low protein, it's a transudate, and it's most likely due to low oncotic pressure is most common for a transudate, and perhaps fluid overload. A modified transudate is a total protein of 2.5 to 5-ish, or 25 to 50 if you're working in grams per litre. And that's more of the effusions due to high hydrostatic pressure, and you get some protein in there from protein leaving the hepatic sinusoids, mostly where there's big gaps in the endothelium. There might be an inflammatory component to modified transudates as well. So this is where you would see like your right-sided congestive heart failure. And then exudates are obviously your inflammatory type fluid. They have a high cell count as well as having a high total protein, or it might be something like FIP causing a high protein exudate in the abdomen. And you can see there's some various cell types there that we tend to associate with these different types of fluids as well. Next slide, please. So then it's on to fluid cytology. So if you have cells in there, obviously you're going to want to take a really good look at them. And if it's an exudate, then the question becomes, is it septic peritonitis or not? Because if it's septic peritonitis, then surgery becomes urgent for that patient in order to get source control of the septic peritonitis. If it's just inflammatory, that's a very different intervention where you might just give medical supportive care. So it's a very different outcome for the patient. So we spend a lot of time going over every single neutrophil in the cytology, looking for intracellular bacteria, because that's really what you need to be sure that you need to go to surgery, is you want to see some intracellular bacteria. Now, I would advise that you base your bets on rods, because cocci can sometimes be a bit misleading. It could be debris in the sample that's misleading you and looking like cocci. But if you see some rods or maybe diplococci, then you can be much surer that those are intracellular bacteria. And you can see on the slide that we have the arrow pointing towards a nice fat rod inside a neutrophil. You might also see neoplastic cells on cytology as well, but those kinds of interpretations are also best made by a clinical pathologist. So I always send out the fluid as well, just to get, you know, a professional's opinion on the cytology. Next slide, please. So here we go into some more specialized tests. And if you're just not sure, you think it's a septic peritonitis, but you're kind of sitting on the fence, you can't see some intracellular bacteria, maybe the patient already got antibiotics, so you're really just not quite sure, you can use glucose and lactate as a supportive test. And this is blood work from a case we had only just last week of septic peritonitis, where we had exactly that. We couldn't find any intracellular bacteria. We really thought that the dog had probably a perforated ulcer from being on NSAIDs. And so we used glucose and lactate as supporting information. So you can see on the left here, the dog's glucose is 5.7 and the dog's lactate is 2.9. And over here in the abdomen, there is a lower glucose of 3.3 and a higher lactate of 6.3. And there's some suggested cutoffs there of how you might use this as a diagnostic test for septic peritonitis. However, I would caution you that this is based on one very small study. And so you can't use these absolute cutoffs, but you can use them as kind of a guide to increase your index of suspicion. Next slide, please. For other tests, this is really going to be guided by your clinical index of suspicion. So for uroabdomen, it might be that you can't find a bladder or the bladder is really small. The patient's usually uremic and maybe hyperkalemic. So you suspect a uroabdomen, and the test you will want are potassium and creatinine on the abdominal fluid compared to the blood. And there's some suggested ratios there of when it is abnormal. And if it's really yellow and the patient also has high blood bilirubin, you might suspect bile peritonitis. And in that case, the bilirubin would usually be more than 2 times that of the blood to diagnose bile peritonitis. The question of culture is an interesting one, whether in septic peritonitis you should submit for culture. What we tend to do in our institution is to do an exit culture. So we do surgery, perform source control, flush out the abdomen and take a culture as we go to make sure that there's no positive cultures of something that might be left behind, because you would presume that you've cleaned up the infection. But there's no hard rule about this. And if you get a pre-surgical culture, then it's still information about the infection there. Usually it's a mixed population, so it may not be helpful. Next slide, please. Sorry, next one again. Okay, so that's what we've gone over for this 12-minute take-home webinar. Being able to identify our fluid by ultrasound, the really important tests, if we could go to the next slide, reminding ourselves that it is the appearance of the fluid, the PCV, total protein and cytology, and some other tests if you have a high index of suspicion. So I hope that was helpful for everyone, just to prioritize what tests you're running on fluid when you get fluid. And I'm happy to entertain any questions.
That was brilliant. Thank you, Lisa. Great questions. I don't know, Amelia, if we've got any questions to ask. that have come through? If not, I've got one of my own that I can ask.
Sure.
I'm a vet in practice as well. So yeah, I was just wondering with with determining if it's borderline transudate, modified transudate and exudate, if you've got a protein level around 25 and you've got a bit of sort of overlap of you're sort of in the grey area of the number of cells as well, and the specific gravity is right on the borderline. Just looking at the cell population that you've got in the abdomen and comparing that to the sort of leukocyte population you've got in the blood, does that give any guidance?
I would say that I guess in this case, we're probably talking about fluid that has a borderline cell number in terms of classifying it as well. So I would look at the cell count, but then I would definitely look at the types of cells in there, whether there's tons of neutrophils versus a more quiet monocytes, mesothelial cells kind of population. I think the type of cells that you'll see in that fluid should be telling as to whether it's inflammatory or not, because you may have a very neutrophilic cell population, but they could have low total protein in their blood and then be third spacing into their abdomen fluid. So it might just dilute out the cells. So those can be tricky ones to say, what is it officially? And I guess you just have to put it together with all the other information from the case to try and make a decision about the underlying cause.
Brilliant, thank you for that. There's a few more questions in the question and answer now. I don't know if you want to have a look at those directly, or
yeah, I'll bring it up. One from Melora. Oh no, might be a tough one. Melora was wondering whether I'm an advocate for diagnostic peritoneal lavage if the volume of fluid was not obtainable, and how this might influence my interpretation. I don't do diagnostic peritoneal lavages. I've just, in my limited experience of them, I've found them unrewarding in terms of being able to find cells that are of diagnostic use. So, because it dilutes everything out and then you've got to spin it down and have a look at the cells. I stick with getting that fluid wherever it is because it's not altered in any way. And I guess we have the benefit of ultrasound and being able to sample really small pockets of fluid. So in that case, I guess we're spoiled that we can target the needle right where the fluid is. But I haven't seen a DPL performed for many years. But I'm interested to know of other people's experiences if it's different to mine. There is another question here. I'm sorry, I don't know how to pronounce your name. While sampling, do you centrifuge the same and then look at it under the microscope? Sorry, I'm not sure I understand the question actually. We do always look at cytology. So we do spin it down, if that's the question. We always spin it down and look at the pellet of cells on the slide under the microscope, because usually the cells are too dilute if you don't spin it down with a centrifuge. The question about whether it's better to take a culture at the start or end of surgery, that's a really good question, something we discuss in our hospital. Most of the times we're cutting septic peritonitis that are of GI origin. So normally it's a mixed population of bacteria that are not normally resistant to antibiotics or multi-drug resistant. So the information from a pre-surgical culture is usually a pretty standard sort of mixture of things that are sensitive to antibiotics. If you had a case where you really suspected a resistant infection, you might then submit a culture if they had been on multiple antibiotics over weeks, for instance. Otherwise, we do an exit culture to see if there's kind of, as our surgeons would say, anything left behind. But I haven't seen any data on whether these cultures in peritonitis actually change outcome, whether it be pre-surgical or exit culture, and I'd love someone to do that research. Great. Yes, the question was about spinning it down. Yes, spin it down. I'm sorry that I missed that point. Do we have any questions in the chat area, or were those the only questions that we had tonight? Happy to answer any others.
Yeah, we've got a couple in the chat box.
Okay,
So
let me have
AJ.
a look.
Yeah.
Oh, yep, I can see them actually. Oh, people from all over the world. It's lovely seeing where you're all from. What tests should be performed from AJ to check the sample from uroabdomen that it has a high creatinine? So if you go back to the slide where I presented the cutoffs for creatinine and potassium, those are the tests you should perform on the abdominal fluid and then compare it to the blood potassium and creatinine and see how different it is in order to diagnose it. To determine the PCV of the abdominal fluid, can we use a CBC machine? I never have. I don't see why not. Most CBC machines are a flow cytometer, although with in-house machines they may not be. But I don't know why it wouldn't be accurate for measuring hematocrit, because it's really just watery blood in a way. So a clinical pathologist could probably answer this question a lot more eloquently than I am, but I don't see why not. If your centrifuge was broken, sure. Any other questions? I think that was it.
Yeah, I can't see any more questions. Oh, hang on, there's another one that's popped into the question and answer box. I don't know if you can see that, Lisa. Oh, it's another two, actually.
Yes. Okay. Can you explain the different common causes of exudate, transudate, and modified transudate? It might take us a little bit long to go through that for tonight because this is a shorter webinar. I'm just off the top of my head trying to think of the best resource for you. If you like, send me an email at lisa.smart@vetct.com.au. There are some quite useful tables that I'm thinking of from textbooks that can list all the different differential diagnoses. I tend to think about Starling's forces when I think about fluids being in places they shouldn't be. So increased hydrostatic pressure, decreased oncotic pressure, and increased vascular permeability. And that pretty much covers really anything that you can think of, and then organizing your differentials under those three categories. That I find that the most useful approach to these problems. And the other question, so feel free to email me and I can send you more resources on that. And the other question was, why is the PCV higher in the abdomen compared to the blood? So that's because as the dog or cat, as they go into shock, their blood becomes diluted from interstitial fluid. Because the hydrostatic pressure drops in the blood vessel, fluid moves from outside the blood vessel into the blood vessel. So it starts to dilute out the PCV. So the animal is hemorrhaging blood that they had in their system at the time of trauma or at the time of coagulopathy. But their blood becomes steadily diluted over time. So that's why it's usually higher in the abdomen than in the blood. And certainly if you sample it after any fluids, it'll be a lot higher in the abdomen than in the blood. All right, I think those were all the questions.
Yeah, I think that looks like it. Thank you so much for that, Lisa. That was fantastic. And yes, your timing was perfect on the webinar. Thanks everyone for your questions. That was really, really interesting questions as well. And thank you for attending. Hope you all found the session really useful. Please do keep an eye out for our future sessions. Next week, it's actually on a Thursday. So Thursday, the 12th of August, we have anesthesia in geriatrics with Dr. Eva Rioja Garcia, which is at 12:30 p.m. British Standard Time. So please do register. The recording of this webinar will be available on our website, and our YouTube channel shortly, and you'll find all of the previous recordings to our webinars on the YouTube channel as well, so do check that out. And finally, don't forget to download the app to gain quick access to Lisa and the rest of our fantastic team of specialists. We'll be leaving this screen up for a few minutes, so you've got time to scan the QR code. And yes, please do contact us if you have any questions, sales@vet-ct.com. Thank you all so much